Good morning. We're going to talk about the various types of viral agents that cause hepatitis, identify who's at risk with emphasis on the pediatric age group, and understand methods to prevent, treat, and prognostic indicators. Now, there is literally nothing new about hepatitis, although you'll learn some new things in the talk. Epidemic jaundice was really described more than 2,000 years ago. In the 1940s was the first differentiation between hepatitis A and B. In 1955, there was an epidemic in India that was subsequently identified as being due to hepatitis E, which some of you may be familiar with. But if not, you'll know by the end of the talk. And then you see in the 1970s more knowledge about hepatitis B and A. In 1989, and this is an important year for you to know, was the first ability to detect antibody to hepatitis C. And the reason for that is prior to that time, anybody who got a blood transfusion, we knew that there was a risk of transfusion-associated hepatitis. And then now there's additional tests to test for what we call non-A, B, C, D, and E hepatitis. So this question's a little bit tricky, and it's changed over the time period that we've given this talk at the board course. And the question is, the most common form of acute viral hepatitis in children in the United States is, and this is based on 2017 CDC data. So very current, a little bit tricky for you. Is it hepatitis A, B, C, A and B, or A and C? And if you could key in your response. So remember, this is acute viral hepatitis in children in the United States right now. All right, so this is the tricky part. So A used to be right, but currently, because of vaccination strategies surrounding hepatitis A, which we're going to show you, the rates have dramatically decreased. And right now in the United States, hepatitis A and C, the case rates are identical. Hepatitis B has a lower case rate due to vaccination strategies. And ultimately, I anticipate that hepatitis C rate's going to exceed the hepatitis A rate. But right now, they are equal. So how about in adults? The most common form of viral hepatitis in adults in the United States, and this does not talk about antibody prevalence, so hepatitis A, B, C, D, or E. And you guys did great with that. Hepatitis C is the most common form in adults right now. There's an estimated 3.2 to 4 million individuals infected. Of those, about 3 million have chronic infections. Now we're going to talk about hepatitis E later on, and its true incidence is a little bit controversial in the United States. But if we would go around this room, 21% of you have antibody positivity to hepatitis E. So if we considered that was a pathogenic form, we would say that that, in fact, is the most common. But for purposes of your board, hepatitis C would be. All right, so this is the disease burden in 2014, and 2014 represents the current CDC statistics. So if you would go on the CDC website and look at their statistics today, this is what you see. There's about a 2-year lag. So when you see the 2014, this is, like I said, the most current data. So hepatitis A, about a third of the population have ever been infected, but it's not associated with chronic disease, so there's no chronic infection in the United States. Hepatitis B, about 5% of the population have been infected, but the prevalence of chronic infection is about 750,000 to 2 million, and then hepatitis C, we talked about, is almost 4 million. Hepatitis D is not surveyed actively in the United States, and hepatitis E is not known. This is such a big problem worldwide that the United Nations declared World Hepatitis Day, which occurs in July, I believe, every year. And so, like I said, this on a global basis is really a problematic issue. So first we're going to talk about hepatitis A. It's an RNA virus. It belongs to the class Picoreviridae. So if you look at and you break that down, pico means small, RNA, and then viridae. Its effects are limited to the liver, and it only causes an acute hepatitis. You're often asymptomatic with this. In developing countries, most individuals have had it. The prevalence may approach 100%. And it would occur cyclically in developed countries with a peak every 10 to 15 years, but due to effective vaccination strategies, the last US peak was in 1995. And this is really a dramatic case of how you can basically eradicate a virus in the United States. So about a third of adults in the United States have had it. If you look at case reporting, if you look at 1990, there was estimated to be 150,000 actual cases. So this is mandatory reporting. So if you have this virus, you go to the lab, you get your blood work drawn, and it's positive, the lab will report it. But about only a fifth of the time does somebody recognize that you have hepatitis A, so that's why the actual case rate is higher. If we look at the current case rate, 2015, there was only 2,800 actual cases. So compare that over the last 25 years from 150,000 cases per year to 2,800. The highest case rate is in Arizona. Anybody from Arizona in the audience? One person, okay. And a lot of cases in the United States result as a result of adult travel abroad because most kids are vaccinated for that. So this has become the biggest risk factor for that. So this slide doesn't take you all the way back to 1990, but it does take you back to 2000. And as you look at it, you can see really the dramatic decrease in the case rate, and this has really been due to vaccination strategies. And again, this is kind of the most current CDC strategy, CDC data. So the incubation period for this is about a month. The problem is you're contagious for 2 weeks before you manifest symptoms, and that's why there's outbreaks of this. You diagnose it by an increase in your IgM level, which persists for 3 to 4 months. Once you're IgG positive, you are immune, and that persists for years. And we'll have a few of these types of slides, but this is the incubation phase. This is when you're viremic and you're excreting it, but it's before you're symptomatic, before you have an increase in your transaminases. Ultimately, when you become IgG positive for this, you are immune, but this is the issue right here. You're contagious prior to developing any symptoms, and that's why they're epidemic outbreaks. Kids are usually asymptomatic. If they have symptoms, it's like a viral upper respiratory tract infection. That's why they're often not tested for hepatitis A. Adults may be more symptomatic. The disease may be more severe. You can get fulminant hepatitis, and you can die from acute hepatitis A infection. If you are older, greater than 50, or have underlying liver disease, that puts you at increased risk. There's no chronic carrier state. And again, now the rates in the United States are similar in all the states. There used to be a distribution based on the states of residence. And this gives you an idea about incidence by age group in the United States. Oops, too many pointers. Can you advance me back one slide in the back? Maybe not, but you guys can advance back one slide. And so you can see the age rates in the United States and the decline in the age rates here. So this is sorry, one more time. This is in the white is the pediatric white and the orange rates. And you really can see that pediatrics and teenagers were the highest rates and are really amongst the lowest rates now for that. Sorry about that. So how do you prevent it? If you knew somebody was going to a high-risk area, you could give them immunoglobulin. It does not have a durable effect. So if they maintain in that area, they need a booster for it. But you would want to give immunoglobulin in the setting of an acute exposure, a common source outbreak, somebody in the household who had it. In the past, like daycare, custodial care situations were common sources. If you know that anybody who went to a certain restaurant was getting it, you could identify other people who went to the same restaurant, you do that. There have been 2 vaccines available since 1996. Both require a booster dose. There is a concept called post-exposure prophylaxis. I don't know if it's come up earlier in the week or not, which means that if you had a common source outbreak, that you could give vaccine at that time and kind of create some herd immunity in that group. And there's a combination vaccine that's for older than 18. So currently, travelers represent 25% of cases of hepatitis A in children less than 15. High-risk populations are indicated on the slide. By being healthcare workers, we are at risk for this. Keep in mind patients with chronic liver disease, men who have sex with men, IV drug use, non-injection IV drug use, people who work in childcare settings or institutional food handlers for this. And really, this is not so that you remember the details of the vaccination, but you can see the initial vaccination strategy started in 1996. It was for high-risk groups. Ultimately, in 2007, the AAP recommended universal vaccination. And if you go back to that CDC graph, you can really see the impact nationally on that, not just in pediatrics, but as people get older and older age groups with that. So it's been tremendously effective. Okay, hepatitis B. All of the following are true except it's a DNA virus with a mean incubation period of 120 days. A smaller viral inoculum is required for infection than HIV. Parental and perinatal transmission are important routes of transmission. Hepatitis E antigen positivity is indicator of a chronic carrier state, and chronic infections associated with a higher risk of hepatocellular carcinoma. And remember, these are all the following are true except, if you can key in your response. And the answer is D. So hepatitis B surface antigen indicates that you are a chronic carrier state. E antigen, and remember this is lowercase e because we're going to talk about uppercase E with hepatitis E infection, is an indicator of how contagious you are. So B surface antigen positive means you're a chronic carrier if you remain positive for that. All right, so it's a DNA virus. It falls in the group HepaDNA viridae. Remember, if you remember the group, you'll know if it's a DNA or an RNA. There are 8 genotypes, 2 subtypes. In the United States, children who are largely involves in data for children who are born in the United States. B and C are most common. Same for Canada, and it mimics the pattern in Asia. If individuals with hepatitis B who are born in Europe typically have the subtype D. It's a little bit confusing. And E if you're born in Africa. Mortality rate's 1.4%, and worldwide 2 billion people are infected with this. 400 million carriers worldwide, 75% are in Asia, and the endemic areas are indicated on the slide. So in the United States, less than 1% carrier prevalence, but that's about 2 million people now. The majority of individuals with hepatitis B currently in the United States are foreign-born. Only about a third are aware that they have hepatitis B, and only 2.5% are on therapy for it. So in terms of the infection rate, there was 46,000 infections in 2006, which was already an 80% decrease from 1990. The current infection rates are 19,000 cases. How many people are from Ohio, West Virginia, Kentucky, or Tennessee in the group? Raise your hand. See where people are from. Oh, so you guys are from all over. All right, well, we're in trouble here in the state of Ohio and our surrounding states because 8 states in the United States, including Ohio, Tennessee, West Virginia, and Kentucky, which surrounds us, represent 60% of acute cases of hepatitis B currently. So you can see the states that are driving most of the acute hepatitis in the country right now. So here's a slide that shows the decreased level, again, largely related to vaccination strategies. Unfortunately, we've not gotten to the low rates of hepatitis A, and the rates have leveled off with this. What are your risk factors as a child? It's really if your mother is positive, particularly if she's E antigen positive. The perinatal vertical acquisition is the largest group of new pediatric infections. The risk for a baby who does not receive vaccine and immunoglobulin at birth is 90% risk of transmission. Later on, IV acquisition, drugs, blood products, and institutionalized care, especially in the setting of biting. So these, again, are the CDC data, and the CDC shows the pediatrics in black, and I couldn't really change this slide for you. So this age group is low, but this age group, which is our 20 to 29 age group, is not low. And so that is a problem. So the rates have gone down, but they're still pretty common occurring. So this is an active issue. High-risk groups are IV drug use, multiple sexual partners, men who have sex with other men, and communities with large number of immigrants from endemic areas. So in the United States, if you look at programs that do international adoptees, about 5% will have hepatitis B. Keep in mind that the family members of adoptees should be vaccinated. So if you take care of patients or families in your practice who are going to adopt a child from abroad, do not rely on the testing from abroad, and make sure that the parents and siblings are adequately vaccinated for hepatitis B. Largely now in the United States and Canada, children of immigrants from endemic areas are the ones who are infected with hepatitis B. The children may be immigrants themselves, or they may be born in the United States and Canada, and the risks vary. So in Canada, 14% of the children with hepatitis B virus are adopted. They are largely of Asian descent, but a large fraction are immigrants from Asia, versus in the United States, there's a higher fraction of adopted children with hepatitis B. And keep in mind that there can be horizontal transmission within a household or enclave. So that's why it's important that siblings and parents be vaccinated. Hepatitis B, almost everybody gets this who has infection. It goes up coincident when you increase your liver function test. If this remains positive, no matter what else happens, you are a chronic carrier by definition. The E antigen, remember lowercase e is a marker of how contagious you are. E antigen positive, more contagious. E antibody positive, less contagious. Anti-HBC, which is an antibody to the core antigen, is only associated with natural infection. You do not get this with immunization. So if somebody's anti-HBC positive, they've had natural infection. Anti-HBE indicates that you're less contagious but not immune, and immunity is only with the anti-HBs. Now, in the setting where we perform therapy for patients with hepatitis B, we measure hepatitis B virus DNA levels, which is a marker of viral replication, and it has important prognostic factors. So this is what happens with acute hepatitis B infection. Here you have your DNA positive E antigen and surface antigen. When you resolve the infection, you become anti-HBs positive. Failure to achieve this indicates you're a chronic carrier. Hepatitis B, we have a higher fraction of patients with clinical symptoms, a higher risk of fulminant hepatitis. Keep in mind these three key numbers. In adults, if you get hepatitis B, your risk of getting chronic disease is 10%. In childhood, 50%. As an infant, 90%. Okay, really important. Infant, 90% risk of developing chronic disease versus an adult, 10%. What's the problem in infancy? You get exposed to a large amount of viral inoculum. You need a very minimal amount of virus to be infected, and you have low immune tolerance. And so when we start to look at labs, normal serum transaminases do not indicate that you're not infected, because babies are immune tolerant intolerant. And so actually an increase in your AST and ALT is a good sign. It means your body's trying to fight off this infection. And then this is chronic hepatitis B infection, and you see that you remain positive for your anti-HBC, but surface antigen remains positive for that. Again, children typically have minimal elevation in their transaminases. That's not necessarily a good sign. They typically have very high HBV DNA levels, and they're asymptomatic till cirrhosis. And the sequence is inflammation to necrosis, which is cell death, cirrhosis, and hepatocellular carcinoma. And if your families that are caring for in your practice are fighting you about why their child needs to be vaccinated for hepatitis B is a carcinogenic virus, and your risk of hepatocellular carcinoma is 500 times more if you acquire the infection than you don't. So if for no other reason, if their child will experience no at-risk factors, again, the effective vaccination helps prevent liver cancer for this. The antibody effective vaccination, you want to develop an antibody response. It's thought that you have immune memory for 15 years. Right now, there's not a recommendation to revaccinate. Vaccination at the time of birth is actually a little bit less effective in terms of durable, but it's essential for prevention of perinatal transmission. Okay, so I suspect ultimately there'll be a revaccination recommendation for individuals vaccinated at birth or high-risk individuals. These are the indications for vaccines. Again, intimate contacts of an acute infection, a neonate is essential, household members, a chronic infection, and a needle stick injury. Again, the routine immunization, 1992, universal vaccination, 1995. You can refer back to those graphs to see the drops in rate. Patients with chronic liver disease, healthcare personnel, residents and staff of institution for individuals who are disabled, hemodialysis patients, patients with bleeding problems, and again, you may need to do a booster for at-risk individuals for this. Immunoglobulin is given only in conjunction with vaccine. It has a synergistic effect, which means it works better in combination than with vaccine alone. So it's about 90% effective, and the indications are indicated. Hepatitis B therapy, this is just to give you an idea what's available. The main therapy right now is a product called alpha interferon. It's a recombinant bacterial product. It's what your body develops when you have the flu. So when you have the flu is what it feels like when you're on alpha interferon therapy. People who do better with this therapy are people who are already mounting an immune response as manifested by an increase in your liver function tests, low HBV DNA, and of acquiring the infection horizontally, being anti-HIV negative, and active liver serology for that. And then this gives you an idea why we perform antiviral therapy. The main reason is to prevent that sequence from fibrosis to cirrhosis to cancer for that. This tells you about what the alpha interferon is. Again, it's produced by recombinant DNA techniques. These are alternate therapies used primarily for patients with chronic infection. They're really not ready for prime time in the United States for pediatrics right now. Some are in the research phase. Some are associated with development of mutations with the hepatitis B virus. Liver transplantation is an option, but you have to immunoprophylax the patients after transplant, otherwise they get recurrence in the graft. And if you don't prophylax them, it's a 75% recurrence associated with a very high risk of graft loss. Hepatitis delta goes along with hepatitis B because it's a defective RNA virus. There's 7 genotypes. It requires the machinery of hepatitis B to replicate. The components are indicated on the screen, and it's endemic in multiple areas. You can see it on this by the CDC. We have a low incidence generally in the United States. It is prevalent in some areas in Europe, Africa, and South America. Co-infection means you get the hepatitis delta and B at the same time. Superinfection means that you're already a hepatitis B carrier and you get the infection on top of it. It's measured by IgM antibody to hepatitis delta. It basically takes everything that happens with hepatitis B and makes it worse. It causes acute hepatitis, fulminant liver failure. It's directly hepatotoxic, higher risk of cancer, higher risk of needing a transplant, higher mortality rate with it. So in the setting of effectively treating hepatitis B with delta co-infection, if you develop the anti-HBs, you'll resolve the delta infection, as evidenced by the HDV RNA being negative for that. In the setting of chronic infection, you remain surface antigen positive and HDV RNA positive. Prevention, if you're vaccinated against hepatitis B, you will not get hepatitis delta. The therapy is similar with a longer duration, no clear prognostic indicators. It may have a slightly better prognosis after liver transplant, and the NIH right now is working on medicine called prenylation inhibitors, which is in research phase specifically for hepatitis delta. So moving on to hepatitis C, which is the big player for you right now. Which of the following is true of hepatitis C infection? A, patients may be asymptomatic. B, there's no chronic carrier state. C, detection may be delayed because of a delay in antibody formation. D, transmission is primarily fecal-oral. E is A and C. And F is B and D, if you could key in your response. All right, you guys did great with that. So patients may be asymptomatic and detection may be delayed because of a delay in antibody formation. So hepatitis C is a single-stranded RNA virus. It causes about 85% of what we used to call chronic non-A, non-B hepatitis. It's primarily parental exposure. The incubation varies widely. 90% of people who get it are antibody positive at 3 months, and this antibody is not protective in any way. So unlike hepatitis B, hepatitis C antibody is not a protective antibody. Antibody testing was available in 1989, 1990. The particle was actually only identified in 1994. It's a single strand. It encodes a single polypeptide. The reason why I include the components is on your testing, you may see something like NS1, NS2, which means like non-structural region 1 and 2. So that's what they're testing for. This is what it looks like. It's classified in the family Hepa C virus. There are multiple genotypes which are significant in terms of treatment. It replicates preferentially in the hepatocyte, and there's multiple mechanisms of action. What's going on currently in the United States in hepatitis C? 2015, 33,000 actual cases. Remember, I told you this has now overtaken hepatitis A. Again, unfortunately, in our area here, so Kentucky, Tennessee, Ohio, Pennsylvania, Indiana, we and the surrounding 10 states or whatever represent 60% of cases, and the highest current rates are West Virginia, Kentucky, Tennessee, and we have seen issues in Ohio because of this. The highest increase in acute cases is in patients 20 to 29, and it has to do with injection drug use, and it's thought that this is kind of a secondary effect of OxyContin use and then moving on to injection drugs. 15% of patients who have it currently have sexual contact with an HCV-infected individual, 30% multiple sexual partners. And this to me is really disturbing. Again, remember all our other graphs, things at least look like they're getting better. And you can see 2010 on. And remember, we're 2 years behind on this, that the rates of hepatitis C are increasing in the United States. 3.5 million individuals infected, about 0.2% of children, but the adolescent rate is likely to go up. The majority of older individuals were infected in the 70s and 80s. Worldwide prevalence is at least 3% in the world. People who have a large blood product exposure, individuals who are homeless or incarcerated, if you take care of any patients in your practice who are inmates, hemodialysis patients, patients who engage in high-risk sexual behavior, and all of us as healthcare providers. And this gives you just a breakdown of some of the risk factors. In the past, surgery used to be important, less important now that blood products are screened. And again, some CDC data just for your interest, what patients self-identified as their behavior contributing to the hepatitis C infection. In the United States, the leading U.S. pediatric cause is mother-to-baby transmission. About 1% of pregnant women are positive for hepatitis C. It causes at least 60% of infections in children right now. Transmission rate, mother-to-baby, if the mother's positive, is about 6%, unless the mother is also HIV positive, which is 20%. Elective cesarean section may have a role in terms of lowering transmission rate, but not yet recommended. If the mother acquires hepatitis C during pregnancy, you cannot treat her because the medicine for it is teratogenic. Perinatal infection, you can develop it some months after birth. Chronic infection, again, recipients of blood products, patients with hemophilia, patients who had malignancy, leukemia when they were younger, cardiac surgery, and there was a batch gamma guard contamination. This gives you the CDC data by specific age group, and you can see that 20 to 29 age group is really a huge problem now in the United States. And again, I think that that's going to move down to our adolescent patients. Kentucky is the highest state right now in the United States for hepatitis C infection. It has been largely associated with drug use there. The rate in women of childbearing age has increased 200% in the last several years in Kentucky. And again, so all of us who take care of patients in this region keep this in mind. How do you detect it? With a PCR test. ELISA is highly sensitive and specific. The Reba test is confirmatory. There's no IgM tests. Keep in mind that your antibody is not protective in any way. How you would know somebody resolved their infection is if their hepatitis C virus RNA became negative and then stayed persistently negative with this. What do you do? Test for babies, for mothers who are positive. You can measure hepatitis C virus RNA at 2 and 6 months. Really what you need to determine is that they're anti-HCV negative at 15 to 18 months of age. Breastfeeding is generally considered to be safe. So what are the manifestations? Typically mild. Remember what we told you with hepatitis B? Is if you're an adult who gets hepatitis B, you have a 10% risk of developing chronic infection. For hepatitis C, all players, 80 to 85% risk of developing chronic hepatitis, and this is why this is so problematic. Mortality rate's 2%. It's the highest cause of liver transplantation right now. So the number one indication for liver transplantation in the United States is hepatitis C infection. The mortality is expected to triple in the next 3 years. Of individuals who are infected, half of them develop cirrhosis. Therefore, 25 to 40% of individuals infected with hepatitis C will go on to develop cirrhosis. This is also highly associated with hepatocellular carcinoma, which can be asymptomatic. With chronic infection, your hepatitis C virus RNA stays positive. Your transaminases may fluctuate as shown on the screen. No prevention, except for things like universal body fluid precautions. No vaccine yet. It has to do with the heterogeneity of the virus. Your risk following a needle stick injury is about 2%. In the setting of liver transplantation, there's a high risk of recurrence. So the 5-year patient survival following liver transplantation is 72%. The graft survival is only 55%, which is really very low. Again, this kind of gives you the natural history of it. Initially, the best treatment for it was the availability of pegylated interferon. It's the same interferon that is used for hepatitis B infection. With hepatitis C, you do better if you have lower levels of viral replication and lower transaminases, if you've had a shorter duration of infection and you're in a younger age. And actually, if somebody has acute hepatitis C and you're able to document that, they may do very well with therapy. Genotype is important in terms of therapeutic outcomes. The best results are with type non-1. Unfortunately, in the United States, type 1 is the most common. And how we know that somebody's responded is if they persistently lose HCV RNA, normalize their liver function tests. Remember that anti-HCV is not protective and will persist. Newer therapies are ribavirin. It's administered only in conjunction with interferon. Hemolysis is a potential complication of it. Pegylated interferon, which requires less frequent administration. There's 2 products available, and it was FDA approved for children in 2008. This hepatitis C has been an exciting area, and you've all seen about it on TV if you watch TV commercials at all. 2013, there became second-generation protease inhibitors were available, FDA approved, greater than age 18. They were given it in combination with interferon and ribavirin. 2015, the first approval of interferon-free regimen for genotype 1, and that's what you're seeing on TV. Sofosbuvir and ladisposvir is the 2 acting antiviral agents. They have a sustained viral response greater than 90%, which is astounding with it. They're incredibly expensive. A treatment course may be $160,000 or more. So it's $1,000 a day for treatment with this. Really exciting news on the pediatric front. There have been 2 trials recently in the United States. They're actually in press. They haven't been published yet. One is for genotype 1, which is the type most common in the United States. I really just wanted to include the reference for you and for you to look at this. A 98% sustained viral response at 12 weeks of therapy. So really great news for adolescent patients who have hepatitis C. So if you have patients, you should refer for these regimens. Similar trial, same institutions, but this was the European component for it, for genotype 2 and 3. Again, I can't go backwards, but 98%, thank you, 98%. Can you take me back one slide? 98% SVR at 12 weeks for this. So really great news. Both of these trials are in press right now. The reason why it's important that you know is that on the basis of these 2 trials, the FDA approved in April of this year these regimens for hepatitis C in adolescents greater than age 12 and a weight greater than 35 kilograms in the United States. So great news for your patients with hepatitis C. Hepatitis E is one of the last 2 agents we'll talk about. It's similar to hepatitis A. It's in the genus Hep E viridae. It's detected by research techniques. You can't order this test at your lab. Initially, we thought it was more common in India, Middle East, Asia, Africa, and Mexico. It turns out it's common in the United States and a lot of other places. This gives you the CDC in terms of the prevalence for it, but there are different types of it that have different clinical manifestations. It causes worse disease than hepatitis A. It has a mortality rate of 1% to 2%. We know that it can be associated with consuming certain types of meat, venison, boar, and pork, contaminated water sources in India. It has a high case fatality rate in pregnant women and can cause premature delivery. And in countries like India and Nepal, it causes 50% of acute liver failure. In the United States, it's significant for patients who are immunocompromised, organ transplant, patients with malignancy, chronic hepatitis. CDC, however, is now doing testing for this test if you have individuals who you think are potentially infected. Remember, I alluded to at the front that this is probably, in fact, the most common form of viral hepatitis in the United States. Based on data from the NHANES study, it looks like 21% of U.S. residents have antibody to hepatitis E, but it's genotype 3, which is thought to be less pathogenic for it. Hepatitis G is an RNA virus in the group Flaviviridae, similar to hepatitis C. It's community acquired. Worldwide distribution, it causes acute and chronic hepatitis. It is blood-borne and it is present within the United States blood donor pool currently. Antibody detection does not exclude viremia. Right now, that blood pool and blood donors are not being actively screened for this. Other causes of hepatitis, keep in mind EBV and CMV, various medications that your patients can be on, alcohol use, anticonvulsants. Mushroom poisoning, we have every few years a case of mushroom poisoning at the clinic. Sometimes we have multiple family members who are affected with this. and other causes of hepatitis, Wilson's disease, alpha-1, autoimmune disease, and inflammatory bowel disease. Thank you very much.